Once we understand this is how glaucoma works and how the damage happens, then in order to prevent that damage from taking place, all we pretty much need to do is reduce the pressure within the eyeball. The pressure within the eyeball is controlled by the aqueous humor. More aqueous humor, higher pressure; less aqueous humor, lower pressure. So all of the anti-glaucoma medications are going to be regulating the amount of aqueous humor within the eyeball, either by decreasing production or increasing outflow. If I decrease production, less is going into the eyeball. If I increase excretion or drainage of the fluid, more is coming out of the eyeball. Both of them is going to lead to a reduction in pressure, thereby minimizing any damage to the optic nerve. Everybody okay so far?
Yes, sir.
Right. So let's get into the slides. Glaucoma refers to a group of eye conditions that lead to damage to the optic nerve. This nerve carries visual information from the eye to the brain. In most cases, damage to the optic nerve is due to increased pressure in the eye, also known as intraocular pressure. So if the intraocular pressure is too high, that is what is going to lead to the damage of the optic nerve. So we're going to look at these videos in a little bit. So we say here that glaucoma is the second most common cause of blindness in the United States. And we have four types of glaucoma, four main types of glaucoma. We have open angle glaucoma, we have angle closure or acute glaucoma, we have congenital glaucoma, and secondary glaucoma. So we're going to get into a little bit of each one. So open angle chronic glaucoma, this is the most common type of glaucoma. The cause is unknown. An increase in the eye pressure occurs slowly over time, and the pressure pushes on the optic nerve, ultimately leading to damage. Open angle glaucoma tends to run in families. People of African descent are particularly high risk for this disease. So, on average, that would work out to about 45% of our population, give or take, are high risk for this disease. And because we genetically mixed. It's not just persons who look like they are African. Because of the genetic mixtures that takes place, persons generally within the Trinidadian population should be screening for glaucoma. So this is pretty much what the eye looks like. You all would have learned this somewhere else. This is the within the eyeball. This is the aqueous humor within the eyeball. This is the optic nerve to the back. And we say it as the pressure pushes against the eyeball, it forces it against the skeleton. And this is where the optic nerve now gets damaged due to that increase in pressure. So we have the angle or the trabecular, this will give me trouble, trabecular meshwork. This is where the aqueous humor drains out from. So a lot of our drugs going to work here, causing the aqueous humor to drain out, thereby dropping pressure within the eye. So angle closure or acute glaucoma, this occurs when the exit of the aqueous humor is suddenly blocked. This causes a quick, severe, and painful rise in the pressure within the eye. So in the same little space that I showed you here, this is where the fluid drains out from. And if for some reason this area gets blocked, it's going to cause a rapid rise in the in the pressure within the eye. So you see the channel gets blocked here. Because the channel is blocked, no fluid can leave, and that results in the pressure going up very quickly. And then you have the damage to the optic nerve taking place at the back here. So let me just get one of the videos here.
Glaucoma is a group of eye diseases in which the optic nerve is damaged, leading to
Again,
irreversible
okay?
loss of vision.
Yes, sir.
In most cases, this damage is due to an increased pressure within the eye. The eye produces a fluid called aqueous humor, which is secreted by the ciliary body into the posterior chamber, a space between the iris and the lens. It then flows through the pupil into the anterior chamber between the iris and the cornea. From here, it drains through a sponge-like structure located at the base of the iris called the trabecular meshwork and leaves the eye. In a healthy eye, the rate of secretion balances the rate of drainage. In people with glaucoma, the drainage canal is partially or completely blocked. Fluid builds up in the chambers, and this increases pressure within the eye. The pressure drives the lens back and presses on the vitreous body, which in turn compresses and damages the blood vessels and nerve fibers running at the back of the eye. These damaged nerve fibers result in patches of vision loss, and if left untreated, may lead to total blindness. There are two main types of glaucoma: open angle and angle closure. Open angle glaucoma, or chronic glaucoma, is caused by partial blockage of the drainage canal. The angle between the cornea and the iris is open, meaning the entrance to the drain is clear, but the flow of aqueous humor is somewhat slow. The pressure builds up gradually in the eye over a long period of time. Symptoms appear gradually, starting from peripheral vision loss, and may go on unnoticed until the central vision is affected. Progression of glaucoma can be stopped with medical treatments, but part of the vision that is already lost cannot be restored. This is why it's very important to detect signs of glaucoma early with regular eye exams. Angle closure glaucoma, or acute glaucoma, is caused by a sudden and complete blockage of aqueous humor drainage. The pressure within the eye rises rapidly and may lead to total vision loss quickly. Certain anatomical features of the eye, such as narrow drainage angle, shallow anterior chamber, thin and droopy iris, make it easier to develop acute glaucoma. Typically, this happens when the pupil is dilated and the lens is stuck to the back of the iris. This prevents the aqueous humor from flowing through the pupil into the anterior chamber. Accumulation of fluid in the posterior chamber presses on the iris, causing it to bulge outward and block the drainage angle completely. Acute angle closure glaucoma is a medical emergency and requires immediate attention.
Right. So now we're going to look at the anti-glaucoma medication. Now we have one, two, three, four main categories that we're going to look at. First group is known as the prostaglandin analogs. Latanoprost is the drug name, Xalatan is the brand name. The beta adrenergic blockers, Timolol is our drug name, Timoptic is our brand name. The carbonic anhydrase inhibitors, brinzolamide is my drug name, Azop is my brand name, and we have the direct acting cholinergics, which is the pilocarpine. So these are the four classes of anti-glaucoma medications that we're going to be looking at. So when we're looking at the prostaglandin analogs, they all end in O-prost. So you have latanoprost, travoprost, brimatoprost. So they all end in O-prost for the prostaglandins. So these are the three examples of prostaglandins that are available within the government system. So how do prostaglandins work? They reduce intraocular pressure by increasing the outflow of aqueous humor. Remember, we said that in glaucoma, the aqueous humor, when the volume within the eyeball gets too high, that is what causes the pressure to go up, causing the damage to the optic nerve. The prostaglandins reduce this pressure by reducing the amount of aqueous humor within the eyeball by allowing more to flow out of the eyeball, thereby dropping the volume and dropping the pressure. Studies suggest that the main mechanism of action is increased uroscleral outflow. The recommended dosage for the prostaglandins is 1 drop into the affected eye or eyes once daily in the evenings. If one dose is missed, treatment should continue with the next dose as normal. It has been shown that administration of the prostaglandin drugs more than once daily may actually cause, more than once daily may increase intraocular lowering effect and cause paradoxical elevations in intraocular pressure. What that last point really means is this. The recommended way to use the prostaglandins is 1 drop within a 24-hour period. They are saying if it is the patient uses more than 1 drop within a 24-hour period, instead of the pressure in the eye going down more than it should, you actually have the opposite effect where the pressure in the eyes start going back up. So you should only administer prostaglandins once in a 24-hour period in order to avoid what is known as paradoxical elevations in intraocular pressure. Everybody clear on that point, or is still a little bit gray?
I'm clear.
Clear? Okay. So usually we will say to a patient when they miss the dose of a medication, take your medication when you remember, and then you go back to your normal schedule. In the case of the prostaglandins, once you miss that dose, you just forget about it and you use it the next schedule time. Otherwise, you'll end up using the drug more often than once in a 24-hour period, and that leads to problems. So, common side effects, changes in the pigmented tissue in the eye may occur. So you have gradual changes in eye color, increasing the amount of brown pigment in the iris. So person who start using the prostaglandins, let's say their eye color was a light brown initially, and over time, where they're using it every day over a period of time, they would recognize that the eye color changes from light brown to a darker brown. That's a side effect of the drug. What we also saw happening with persons who use prostaglandins is that you had changes to the eyelashes, including increased length, thickness, pigmentation, and number of lashes. That kind of sounding like one of them L'Oreal commercial, right? Luscious lashes, where increase in volume, increase in length. Because of this side effect from the prostaglandin analogs, those beauty companies were able to go in and isolate the compounds that were actually causing this effect and then market them as separate products that increases the length of the eyelashes, that increases the thickness of the eyelashes, that increases the number of the eyelashes. These are listed here as side effects for the drugs, but these beauty product or beauty companies, they use them specifically for these side effects that we have here. Everybody okay with that?
Yes,
Yeah.
sir.
Right. So the second group that we're going to look at is the beta adrenergic blockers. We met beta blockers a couple of weeks ago when we looked at beta blockers that were being used in the heart. We saw atenolol and propranolol. Now, they were beta receptors within the heart. We also have beta receptors within the eye. So you notice the beta blockers here also end in lol. We have timolol and we have betaxolol. Those are the two beta blockers that are available within the government service to be used within the eyes. So mechanism of action for timolol Timolol causes a reduction of the pressure within the eye by a reduction in the production of the aqueous humor within the eye. So when we looked at the prostaglandins were increasing outflow, thereby reducing the amount of aqueous humor within the eye. The beta blockers, they tackle the problem from the other angle. They tackle it from the production side. So the beta blockers decrease production of aqueous humor, thereby reducing the amount of liquid within the eyeball. Once that happens, the pressure goes down and you have less damage to the optic nerve. The precise mechanism is not known, and timolol was first approved by the FDA for ocular use back in 1978. In 1978, timolol was the standard by which glaucoma was managed. That was your go-to drug. The prostaglandins are now the standard by which glaucoma is managed. That's your first line drug. Any drug coming onto market that is attempting to manage glaucoma, they must demonstrate their efficacy against the prostaglandin analogs. So any new agent coming to market must say, compared to the prostaglandin analogs, this is how well I work. And to date, we haven't seen many products, and that is why the prostaglandins are now the standard, because they have the best intraocular lowering effect as well as safety profile compared to some of the other agents that we have access to. So typical side effects: blurry vision, bitter, sour, unusual taste in the mouth, dry eyes, temporary discomfort, itching of the eyes, feeling as if something is in your eye discharge, headaches may occur. Now, before we move on to the other group, I want us to just go back up here and pay a little bit detail to our two examples. When we're talking about dosage forms, we see in here these are both eye drops. But let's look more specifically at what type of eye drops they are. The timolol is a what?
So it's
Solution.
that ophthalmic solution.
Ophthalmic solution,
Yes.
and you learn the definition of what a solution is. Once you put ophthalmic in front of it, we just means that it's for the eyes and that it's sterile. That is the only difference. For the beat optic, what's the dosage form?
Suspension.
A suspension. And you all remember what was the definition for a suspension, right? If this is a suspension, that means it has solid particles as well as liquid particles within that vial. This is a very rare occurrence where literally we are introducing into the eye these solid particles, because when you place the eye drops into your eye, the solid parts move out as well. So you now understand why people just feel as it have something in your eye, because guess what? It have something in your eye. The little solid particles from here. Now they refer to them as microparticles. They're really, really, really small. When you allow the bottle to sit, you can see them settling out over time. And as a result, before the patient use the eye drops, they are required to do what with them?
Shake it.
So shake it.
Shake well before use, right? So because it's a suspension and the particles settle out over time, you'd want to shake the bottle well before putting the eye drops into your eyes. So when we're dealing with these eye drops and these different liquid preparations, we have to pay attention to what the dosage forms are. So the other one is carbonic anhydrase inhibitors. So we have an example here: acetazolamide, Diamox is the brand name; brinzolamide, Azop is the brand name; and with the COSUP, it's dorzolamide or dorzolamide and timolol in combination. So here we see in the first introduction of a combination eye drop with the COSUP. There are two different drugs belonging to two different therapeutic classes, that are in one bottle. So we have now reduced the number of eye drops that the patient has to take, because instead of using two different bottles to get the same drug, we have mixed both of them into one. So it's now just one bottle, so one set of eye drops you put in, as well as the fact that it comes from two different classes. That is important. The other thing we see here is that we meet in the first oral anti-glaucoma medication. The problem is the pressure within the eye. Acetazolamide is the only oral anti-glaucoma medication. Now, the acetazolamide is not routinely used. It's not an everyday kind of drug. The acetazolamide is usually used, and we'll get into it. We're doing it first, carbonic anhydrase. Right. The acetazolamide is generally used after the patients would have had surgery or 1 or 2 days just before surgery. If it is the patient is suffering from glaucoma, but the patient has to do a cataract procedure, you'd want the pressure within the eyeball within normal range. You don't want high pressures, because those high pressures would slow down the healing of the procedure that you would have done earlier. So very often the acetazolamide tablets might be administered a day or two before the procedure, and then continued about 3 days after the procedure, just to make sure the pressure within the eyes stay within range. So that's the interesting thing about this group. We have a solid dosage form as well as a combination eye drop. So how do the carbonic anhydrase inhibitors work? They are sulfonamide. That means they contain sulfur. If the patient has a proper sulfur allergy, then for sure we're going to have the patient reacting to this drug. How it works? It inhibits the enzyme known as carbonic anhydrase in the ciliary processes of the eye. It decreases aqueous humor secretion. So this class of drugs decrease aqueous humor secretion into the eye, and it has something to do with slowing down the formation of bicarbonate ions, which subsequently lead to a reduction of sodium and fluid transport. So here we have less aqueous humor coming into the eye. So we're tackling the product from the production side. Less is being produced, less is introduced into the eye. So as a result, we will now have a drop in that pressure within the eyeball. Everybody okay with that mechanism?
Yes, sir.
Yes, sir.
Right. So the side effects, pretty much the same for the one that we saw before. Temporary blurry vision, bitter sour taste, dry eyes, temporary discomfort, itching of the eye, feeling as if it has something in the eyes, and eye discharge. So the other group is the direct acting choline agents. Pilocarpine is this one. Now you notice I have two pictures there. One is at 2%, the other one is at 4%. These are the two percentages or the two concentrations that are available within the government system. Now, pilocarpine, we met this drug and we spoke on it briefly when we were looking at parasympathetic and sympathetic nervous system, that lecture. We spoke on it briefly, so we're meeting it here in some detail now. So pilocarpine produces contraction of the iris sphincter muscles, resulting in pupillary constriction, which is miosis. What also happens is that the pilocarpine causes constriction of the ciliary muscles, resulting in increased accommodation and reduction in the intraocular pressure associated with an increase in outflow and a decrease in inflow of the aqueous humor. So here we see in the pilocarpine, it tackles the problem from both ends. It increases outflow and it decreases inflow. These are real nice drug. It tackling the problem. One drop, same problem, two different endpoints. two different sides the drug is tackling the problem from. Although the mechanism of action speaks to that, because of this fact that is going to cause meiosis in the patient eyes, because of that one fact, the drug is not widely used. When this meiosis happens, the pupillary constriction, it affects how the person sees. So persons who are using pilocarpine, when they put the drops into the eyes, it not only lowers the intraocular pressure, but is going to cause this pupillary constriction to take place. And that is also affects how the patient sees. So it's not a drug that is used that often. For the persons who end up having this as part of their treatment plan, it means they would have tried all the other classes of drug without success, and they have now added this drug on as a last resort to see what we can do to assist the patient. Common side effects: blurred vision, changes in near vision and far vision, decreased night vision, eye irritation, headache, and brow ache. So this brow ache they're referring to here is the eyebrows, that area there. That is where you have some pain and discomfort taking place. So this table here pretty much summarizes all of this stuff that we have been talking about. We have our timolol drug classes, beta blockers. We have dorzolamide, which are our carbonic anhydrase inhibitors, latanoprost, prostaglandin analogs. So we see in the classes here, you have a quick look at the mechanism of action, who is reducing aqueous humor formation, who is increasing outflow, decreasing formation, some of them doing both. So this table is a nice summary. You also have the frequency with which the drop should be used. Here we see in the latanoprost is once daily, and we know once daily means once in a 24-hour period. You have your side effects, adverse effects, and contraindications where the drug cannot be used. So we see under prostaglandins, it's not contraindicated against anything. The only thing it might be contraindicated against is if the patient has an allergic reaction to it. Beyond that, there is no contraindications. When we look at the timolol, or the beta blockers, we see here that it is contraindicated in bradycardia, heart block, heart failure, asthma, obstructive airway disease. Keep in mind, all of these areas, the lungs, the heart, they are all populated with beta receptors. And some of these receptors might be selective, some mightn't be that selective. So in some persons, you may find that the drug goes and attaches to receptors in the body that it really shouldn't attach to, and that's where you get these side effects taking place. So we looked at glaucoma, we looked at the drugs used there. Now we're going to meet two new terms, mydriatics and cycloplegics. So in the picture I have at the bottom of the screen there, you notice anything about the eyes?
Yes, sir.
What you notice?
So one the pupil is different. One like dilated.
And the other one isn't.
No.
So,
Yeah.
right. So this is what the person's normal pupil looks like. And this is what the pupil became. See how big it came? It picks up almost 80 to 90% of the area now, compared to this one where you still had a lot of color going around. Here, you hardly have no color, so the pupils are fully dilated. So what we're saying here is mydriatics are drugs that cause dilation of the pupils. Just as how we had anti-glaucoma drugs, we had the prostaglandin analogs, we had the beta blockers. We now see in a group of drugs here, mydriatics, whose core function is to dilate the pupil. Very often, the reason we need to dilate the pupil is order to give the physicians a look into the back of the eye to see what's happening, as well as if there are any procedures to be done within the eyeball They normal in some instances they go through the pupil after it has been dilated. Any questions on mydriatics before we go on?
No, sir.
Okay. So cycloplegics. So we met mydriatics. Now we're talking about cycloplegics. Cycloplegics are drugs which cause paralysis of the ciliary muscles within the eye. So let's just go back up and see this ciliary muscle thing that they're talking about. Where exactly is it? So the ciliary body, these are these little bits of fiber that hold the lens in place. But they do more than hold the lens in place, and we'll get into them shortly. What is happening here is that they are holding the lens, and when they contract and relax, they allow the lens to thicken or become thinner. When that happens, is referred to as the accommodation of the lens. So cycloplegics are drugs which cause paralysis of the ciliary muscles within the eye. Once that happens, it stops. The term that we use is accommodation. The lens in the eye has now lost the ability to become thick or to get very thin. And that thickness of the lens, or it becoming very thin, is one of the ways in which the eyes focus for vision at different distances. So you might say, all well and good, all right, Java 20, a very small so let me just get back to the point here. Sorry about that. So we're saying here that it stops the accommodation in the eye and the focusing of vision at the. So we understand asthma, we will understand what happens in asthma. Let's talk about chronic obstructive pulmonary disease, which is COPD. Chronic obstructive pulmonary disease. Based on the name, pulmonary is the lung. Chronic, that means it's continuous, long term, as opposed to asthma, where we have the acute asthma attack and then it's relieved. This one is chronic, it's long term, and it's obstructive. So, where the lungs are obstructed for a prolonged period of time, chronic obstructive pulmonary disease. So, what is COPD? So, COPD actually refers to a group of lung diseases that block airflow and make breathing difficult. COPD is not one disease. It's a group of diseases that block airflow and make breathing difficult. The two common conditions that make up COPD is emphysema and chronic bronchitis. We're going to get into these two and understand them. So in chronic bronchitis, chronic, long-term, bronchitis, itis of the bronchioles, inflammation of the airways. So chronic bronchitis is inflammation of the lining of the bronchial tubes, which carries air to and from the lungs. We learned during the semester that once we're talking about inflammation, we are going to have swelling. Swelling is one of the things that happen during inflammation. So if it is we have the airways inflamed, that means they are swollen. And if they are swollen over a prolonged period of time, then that means they are constricted and cannot carry as much oxygen as they should. So chronic bronchitis is inflammation of the lining of the airways in the bronchial tubes, which carry air to and from the lungs. We okay with bronchitis?
So, yeah.
Let's understand emphysema now. Emphysema occurs when the air sacs, known as the alveoli, at the end of the smallest air passages, which is your bronchioles, in the lungs are gradually destroyed. What's the function of alveoli in the lungs?
Gaseous
Gaseous
exchange.
exchange.
Gaseous exchange, you're right. So if the alveoli is damaged, could gaseous exchange take place?
No.
No.
And that's the problem with emphysema. Once the alveoli are damaged in emphysema, the lungs gradually lose its ability to exchange oxygen. So emphysema is irreversible. Once those alveoli are damaged, they're damaged for the rest of the patient's life. You're not bringing them back. And if we don't get control of the emphysema in the early stages, it's just going to progress and progress and progress. And more alveoli will be destroyed, resulting in the lungs losing its capacity to exchange gases. To exchange, go ahead.
But I work in the hospital and I work in the medical ward and they said not to give them no oxygen, but give them it in low doses, like 1 ml, 1 liter, but give them it in low doses because the alveoli can get damaged. I don't
So,
know
sorry,
what oxygen.
I didn't get the ending up. I heard where you said not to give them oxygen, but give them a low dose of what?
And they can give them a low dose of oxygen therapy, but not to give them a high dose of oxygen therapy.
Right.
That was what
As we go along, we will look at the different therapeutic options for COPD. So what we were doing right now is understanding the two components that make up COPD and understanding what effect it has on the body. Then we will get into the treatment in the next couple of slides.
okay.
Right. So we're saying here that damage to your lungs from COPD cannot be reversed, but treatment can help to control symptoms and minimize any further damage. So when we look at the symptoms for COPD, we will recognize that the symptoms for COPD are similar to what we would have seen in asthma. So we have the shortness of breath, especially during physical activities, wheezing, chest tightness, having to clear your throat first thing in the morning due to excess mucus in your lungs, and a chronic cough that produces sputum that may be clear, white, yellow, or greenish in color. So as the sputum goes from clear to white to yellow or green, what does that convey to you? What's happening with the patient?
So that means the patient is well, it is infected because if the it getting from clear to a kind of greenish color, so that
Right.
means the
So
lung.
it means the patient has a lung infection. So for persons who suffer with COPD, they are prone to lung infections. So they may generally have a cough, but then at various points in time during the year, that cough may now start to produce sputum that goes through this color change. That implies that in addition to their COPD, they now have a lung infection as well. And at those points in time, we may now need to specifically treat the lung infection while still maintaining management of the COPD. So COPD is not just the airway narrowing, we also have the possibility of infection and managing those infections. Symptoms of COPD: blueness of the lips or fingernail beds, which is known as cyanosis. Why would the lips be blue or the fingertips be blue? Any thoughts on that?
Not enough oxygen.
Block of oxygen.
Right. Remember we said the alveoli are responsible for gaseous exchange. If the alveoli are damaged, therefore we cannot exchange oxygen as efficiently as we would like to. So carbon dioxide will build up within the body as the lung is unable to now exchange oxygen as quickly as it needs to. Therefore, the lips will get blue and the fingernail beds will be blue. Frequent respiratory tract infections. So again, once you have COPD, you run the risk of this lung infection happening. Lack of energy. Where the lack of energy comes in from is in order for the body to produce energy, it normally carries out what is known as aerobic respiration. But if it is we unable to effectively transfer oxygen, could we carry out aerobic respiration effectively?
No, sir.
No. So therefore, the person would lack energy. The body will now go into anaerobic respiration in order to generate energy. But that in itself can't be maintained long term. The body uses anaerobic respiration and as a short-term measure until the body can effectively get back to aerobic respiration. But in these patients who have long-term problems in getting oxygen into the blood, the body just going to be lacking enough energy because the respiration can't take place as well as it should. And in the later stages, it has unintended weight loss. So chronic obstructive pulmonary disease, COPD, just to summarize, consists of chronic bronchitis and emphysema. In chronic bronchitis, it's inflammation of the bronchioles, which leads to swelling of the bronchioles, which is narrowing of the bronchioles, as well as excessive mucus. In emphysema, the alveoli breaks down, and once the alveoli breaks down, you have insufficient or inefficient gas exchange happening in the lungs, which would result in carbon dioxide building up in the patient and they not having enough oxygen for respiration. Everybody okay so far?
Yes, sir.
Right. So in COPD, symptoms don't appear until significant lung damage has occurred. And when the lung damage has already occurred, if it is you don't try managing it at that point in time, the damage is only going to worsen. So the key thing about COPD is recognizing that you have it early on and then effectively managing it so therefore it doesn't worsen. We cannot reverse the effects of COPD once it has happened. So for chronic bronchitis, the main symptom is a cough that persists at least 3 months a year for 2 consecutive years. You all ever heard persons refer to the smoker's cough? You all ever heard about that?
Yes, sir.
Right. So think about what the smoker's cough does be like, and that same thing happening in the patient, just they don't smoke. In some cases, the smoker's cough may not only be caused by the cigarette smoking, but it could also be the early stages of COPD happening in that patient. Very often, persons who smoke cigarettes, they tend to develop COPD. Not all of them, but cigarette smoking is a risk factor for developing COPD. On the other hand, we have people who never smoke in their life, never vape in their life, that may still develop COPD. So it's just a matter of understanding the symptoms and understanding that, if I find I have this persistent cough that lasts about 3 months every year, or it might happen twice a year, or it may be happening over a 2-year period where this cough does come, stick around for some time, and then go, maybe I should have it checked out. Because if it is COPD, the earlier we catch it, the better the outcomes. So this table here just summarizes and compares asthma and COPD. The main difference is that asthma is oftentimes diagnosed early in childhood, whereas COPD is developed later in life. The effects on airflow from asthma is largely reversible, whereas with COPD, it's partly reversible or not reversible at all. Those are the main points that I would want you to take away from this slide here. So now we're getting into the actual treatment management of asthma and COPD. We do the both of them together because one, the symptoms are similar, and if the symptoms are similar, then the way we manage them are going to be similar. And two, when you actually look at most of these drugs or classes of drugs, they are indicated for both asthma and COPD. So we capture all of them here. We look at them, although it's two separate and apart disease states, we look at them collectively because the treatment is very much similar. Everybody okay so far?
Yes,
Yes,
sir.
sir.
Right. So the first class of drug that we're going to look at is the beta agonist. Salbutamol is our drug. We met salbutamol a couple of weeks ago. We're meeting salbutamol again here now. We also seen a relative to salbutamol, which is formoterol. So you notice the N in the ol, so the salbutamol, formoterol. They are not beta blockers in this case. They are beta agonists. They help the beta receptors work better. They're not blocking them off. Anticholinergics, we have ipratropium, we have tiotropium, and we have umeclidium. Those are our three agents under anticholinergic drugs. When we look at corticosteroids, we have beta-metasone and prednisolone. Beta-metasone is normally an inhaled corticosteroid. So in the literature, you might see ICS, inhaled corticosteroid. That is what it stands for. And the prednisolone is available as an oral dosage form, which means it comes as tablets as well as syrup. We see in here the group methylxanthine. Theophylline is the example that we have there. For those of you who would have done the recently submitted group project, you may remember seeing a drug called aminophylline. Anybody remember seeing that drug?
Yes, sir.
Yes, sir.
Yes,
Right.
sir.
So aminophylline is like the precursor to theophylline. It's the same molecule. One does make the other one when it gets metabolized or something like that. So all of the information you would have read and done with aminophylline in your group project, same information applies to theophylline here. Everybody okay with that? Yeah, people?
Yes.
Yes, sir.
Yes, sir.
And the last group is known as the leukotriene antagonists. The example is montelukast. So we're going to dive into this now. So the beta agonists, not beta blockers, not beta antagonists, beta agonists. That means these drugs are going to go and attach to the beta receptors within the lung and help them carry out their normal function. It's going to cause the beta receptors to carry out its normal function more effectively. Our example is salbutamol, which is Ventolin. That's the short-acting one. That's your blue inhaler for any of you who have been around people who suffer with asthma. Their blue inhaler, salbutamol or Ventolin. This is what we're talking about here. And then we have the longer-acting version of Ventolin, which is known as formoterol. And I'll show you where formoterol comes in. So we're saying here that the beta agonists are indicated for the treatment and prevention of bronchospasms in patients with reversible obstructive airway disease. When we say reversible obstructive airway disease, we're talking about here, in this case, the asthma for sure. We know in some instances the damage that has occurred with the COPD cannot be reversed. But if it is we're talking about chronic bronchitis and the itis is causing the inflammation, and the inflammation is causing narrowing, then the salbutamol is still going to be able to go in and attach to those receptors and open up the airways to some extent. So the salbutamol in this case can also be used in the early stages of COPD to help open back up those airways as well. So we see in treatment, when we're talking about prevention, here we're talking about prevention of exercise-induced bronchospasms. What they have found is if persons who suffer with exercise-induced bronchospasms, if they take salbutamol, let's say maybe about 5 to 10 minutes before they start their exercise routine, the incidence of exercise-induced bronchospasm goes down. The patient doesn't get the asthma attack. So the salbutamol in that case would have prevented the asthma attack from coming on, whereas in the other instances, we treated an existing asthma attack. So how does salbutamol work? It stimulates beta-2 receptors, which are the predominant receptors in the bronchial smooth muscles of the lungs. When that happens, it leads to the formation of a compound known as cyclic AMP, and high levels of cyclic AMPs causes the bronchial smooth muscles to relax and decrease airway resistance by lowering intracellular calcium concentrations. Salbutamol relaxes the smooth muscles of the airways from the trachea to the terminal bronchioles. High levels of CMP also inhibit the release of bronchoconstrictor mediators such as histamine, leukotriene from mast cells in the airways. So we would have gone through it. Let's summarize. How does salbutamol work? Stimulates beta-2 receptors, which are the predominant receptors in the bronchial smooth muscles in the lung, resulting in relaxation of bronchial smooth muscles and decreased airway resistance. Everybody got that?
Yes, sir.
Yeah? That was a yes or a no. I didn't hear you clearly.
Yes, sir.
Still didn't get it.
So you hear us?
Yeah, yes, yes, we hear you.
Yeah. Okay. All right. So let's look at some drug interactions with salbutamol. So if it is we're using beta blockers, we have to use the ones that are beta selective. Between propranolol and atenolol, which one is beta selective? The propranolol or the atenolol?
Atenolol.
Right. So what we're saying here, beta blockers may diminish the bronchodilatory effect of the salbutamol if they are beta selective. So your atenolol, although you could take a chance, it might still reduce the effect. Propranolol, which is non-beta selective, we're saying definitely you cannot use that in persons who suffer with asthma. Propranolol should not be used in a patient that is suffering with asthma or COPD, right? Avoid or limit caffeine intake, because if you're taking caffeine along with salbutamol, you're at increased risk for the CNS stimulation, which is nervousness happening. So common side effects: central nervous system stimulation, dizziness, irritability, migraine, nervousness, hyperglycemia. So salbutamol might cause a slight increase in your blood sugar levels. It may also cause a decrease in your potassium levels. So if the patient is diabetic, especially if they're taking the salbutamol orally, you have to look out for this hyperglycemia. If the salbutamol is administered via the inhalers or nebulizers, the hyperglycemia will not be as pronounced since it's going directly to the lung and not into general circulation. So from your group project 1, you would have learned how to use a meter-dose inhaler. For those of you who might have had gaps in your answers, within the e-class, I've posted a video, 2 videos I think it is, that walks you through the steps in the proper use of an inhaler. When I used to teach this, and this course was an in-person course, what I would normally do at this juncture is pick 2 students, have one read the instructions, as to not read, but tell the patient how to use the drug. And as that nurse is telling the patient how to use the drug, the patient is then demonstrating it. And very often, when people see what they said, they recognize where they now need to maybe rephrase it. Because we have a picture in our mind, we meaning the people who saying how to use it. But the people who receiving the information may not necessarily be hearing what we actually say. So look at the videos, get comfortable with the techniques, and then say it to a friend or a colleague and see if the actions that they carry out is what you really wanted them to do. Right? So we see in here salbutamol comes in various dosage forms, syrups, tablets, nebulizing solution, inhalers. How to administer a meter-dose inhaler is part of this content. Although you did not do that part of the project, it is still content that was covered in class. You are required to know how to use it.
Yes, sir.
Everyone is clear on that?
Yes, sir.
Yes, sir.
So now we're moving on to the anticholinergic agents. We have 2 drugs here. We have ipratropium, which is Atrovent, and most of you all would be familiar with this one. And we have tiotropium, which is Spiriva. This one may not be as common. So we see in here that the indications is an anticholinergic bronchodilator used in bronchospasm associated with COPD, bronchitis, and emphysema. So the salbutamol was a beta-2 agonist. The ipratropium is an anticholinergic. So we are attacking the same problem using 2 different receptors. Salbutamol was beta receptor. The Atrovent is the cholinergic receptors. So we're saying that the ipratropium blocks the action of acetylcholine at the parasympathetic sites within the bronchial smooth muscles. When that happens, it leads to bronchodilation. And this is how the ipratropium opens up the airways. Local application to nasal mucosa inhibits serous and seriomucosa gland secretion. So when the patient inhales the nebulizing solution and they inhale the ipratropium and it gets into contact with the nasal mucosa, it also reduces the amount of mucus that is secreted. Remember we said in both asthma and COPD, we had to manage the amount of mucus that is present. This is one of the ways we manage that mucus. Typical side effects: headache, dizziness, dry mouth, taste perversion, and back pain. This is the Atrovent nebulizing solution. The brand that you get in hospital right now is definitely not this brand. I'm not sure which brand you're getting right now, if it's the APO brand. But this is the Atrovent brand. Here we see it, the Atrovent, which is the ipratropium, used to come as an inhaler. And then we saw that the Atrovent was combined with another drug known as albuterol. So albuterol is the same thing as salbutamol. One is American, one is British. So in the brand name, which is known as Combivent, it contains two drugs, ipratropium and salbutamol. Although you're seeing albuterol here is the same thing as salbutamol. So that's what Combivent had in it. So this was an inhaler that had Ventolin and Atrovent mixed into one device. So the same way you would nebulize your patients with salbutamol and ipratropium, this inhaler had both of them mixed into one inhaler. So the patient could have gotten both drugs from one inhaler. Tiotropium. Tiotropium is still under anticholinergic. Tiotropium has a very long half-life. The half-life is like 5 to 6 days. The time to peak in plasma is like 5 minutes. So it does peak in your blood in 5 minutes, but it sticks around for 5 to 6 days. You can't see it very clearly on this picture, but we'll start with this one. This device is known as the Spiriva Handihaler, and one puff or one inhalation carried 18 micrograms, not 18 milligrams, 18 micrograms. Because the half-life elimination is so long, we could use a very, very small dose and get a pretty good therapeutic outcome. So when the drug first came to market, it was 18 grams in one dose. After a couple of years, they redesigned the thing and they came up with Spiriva Respimat. The first one was Spiriva Handihaler. We no longer get any Handihaler. What we're getting is the Respimat. It's a little bit blurry down here, but one dose is 2.5 micrograms. We move from 18 micrograms now down to 2.5 micrograms. You understand how small that dose is? That's a very, very small dose. The Spiriva Respimat, unlike all of your other inhaler devices, requires assembly. You have to put it together. It comes in parts. For some persons, when they did the group project, they didn't tell me how to assemble the thing. Keep in mind, you as the nurse, you know it need to assemble. The first time you're giving it to the patient is none the wiser. So if you tell the patient, just go home and inhale 2 puffs once a day, the patient not going to know they need to load it. Therefore, it is important that you go through all these steps with the patient. 1, that it needs to be loaded. 2, how it should be loaded. 3, after it is loaded, you now need to prime the device. And after it's primed, now it's ready for use. You have to go through the steps with it. And this, again, was covered in your group project. For persons who might have had gaps, there is a video in the e-class that you can look at and understand how to use the device. Everybody okay with this?
Yes, sir.
Yes, sir. Yes, sir.
So we have a relatively new product. I think it has been around maybe a year and a half, 2 years, give or take. Here we are saying that this product, the name of it is Anoro. And what it is, it's a combination of umeclindium, which is an anticholinergic drug, along with valenterol, which is a long-acting beta-2 agonist. So the same way when we looked at Ventolin, we made mention that it had a long-acting one known as formoterol. We now see there's another long-acting one by the name of valenterol. So we're saying here that Anoro is a combination of an anticholinergic along with a long-acting beta-2 agonist. And this combination is indicated for maintenance treatment of patients with chronic obstructive pulmonary disease, which is COPD. So Anoro is relatively new to the market. Most of you are not going to see this up on your wards. Where this drug would have had most of its use would be in the chest clinic. And for those of you who might have passed through Cora as a hospital, that is where you're going to see most of the use in this drug. You would see some of it again in your outpatient setting for the patients who might come back on your ward who were in the chest clinic. They may bring it back up on the ward for you. So you should know how to use the device in the event that they bring it up on the ward for you to utilize. Right? Anoro was one of the drugs that was in your group project. Again, in the E-class, if you might have had gaps in your group project, there is a video there telling you how to utilize it. Corticosteroids. So we have the beclometasone, which is the Bicotide. For those of you who are around persons with asthma, this is their Brong inhaler. The Ventolin or salbutamol is the blue one, that is the rescue inhaler. The Bicotide or the beclometasone, which is the Brong inhaler, that is the maintenance therapy. They use that every day to prevent an asthma attack from coming on. So we're using the steroids to prevent an asthma attack from coming on. In the event that an asthma attack does come on, we then use the salbutamol in order to open up the airways so the patient can get some relief. You understand the difference between the two inhalers, yes, and what functions they play? Right. So airway inflammation is known to be an important component in the pathogenesis of asthma. Inflammation occurs in both large and small airways. Corticosteroids have multiple anti-inflammatory effects, inhibiting both inflammatory cells and the release of inflammatory mediators. The anti-inflammatory actions of corticosteroids contribute to their efficacy in asthma. So in short, the corticosteroids manage the inflammation, they reduce the inflammation, and by reducing the inflammation, we now reducing the swelling within the airways. If the swelling in the airways are reduced, then the patient is able to breathe easier. In addition to which, remember we said that asthma is an allergic type response. The steroids suppress that allergic reaction. So although the patient might have been exposed because the allergic reaction is now inhibited by the steroids being present in the patient's system, we have just prevented an asthma attack from happening. Everybody okay with that?
Yes, yes, yes.
The main side effect with oral corticosteroids is oral candidiasis. Everybody know what that is?
Like Hawaii, naturally inside the mouth, inside the tongue, and inside the mouth.
Yep, that's it. And what it actually is a fungal infection. So just like how with ACE inhibitors, we know is the dry cough, and with phenytoin, we know is gingival hyperplasia. Once we're talking about beclometasone and inhaled corticosteroids, the first side effect that must come to mind is oral candidiasis. That's the first thing that must come to your mind. Because this is the most prevalent side effect, when you did your group projects, persons in the process of how to use the inhaler would have mentioned that when using these inhalers, you have to rinse your mouth out after using these inhalers. By simply rinsing your mouth out with some water, you have now reduced the chance of oral candidiasis happening. If you don't rinse out the mouth after using it, you are more prone to oral candidiasis. Everybody okay with that?
Yes, sir.
Right. So with steroid use, we just looked at inhaled corticosteroid, which is your beclomethasone. We can now use oral corticosteroids, and the most common one is prednisolone. The mechanism of action is that it decreases inflammation by suppression of migration of leukocytes. They also suppress the immune system by reducing activity and volume within the lymphatic system. So for children, the recommended dose is 0.1 to 2 milligrams per kilogram per day, and divided doses 1 to 4 times per day. An adult dose is anywhere from 5 to 60 milligrams per kilogram per day. It may be taken after meals with food or milk. And the reason we ask people to take it after meals is because the drug tends to cause stomach irritation. So we're now going to look at Symbicort. So Symbicort is inhaled into the lungs for treatment of asthma or chronic obstructive pulmonary disease. Symbicort contains two active ingredients, budanoside and formoterol. So we see in here another combination inhaler. But what classes of drugs are here? The first one we saw, which was the Combivent, that had salbutamol and ipratropium, two different classes of drug tackling the same problem from two different angles, both of which were opening up the airways. One was short term, one was longer term. Then we met Anoro. Anoro was an anticholinergic drug as well as a long-acting beta-2 agonist. So again, they were tackling the same problem using different angles or different receptors, both of which led to the opening up of the airways. In Symbicort, this is our third combination. Symbicort is budanoside, formoterol. The budanoside part is the steroid. The formoterol part is the long-acting beta-2 agonist. So here we have the steroid part that is going to manage the inflammation and reduce the inflammation, prevent an asthma attack from coming on, whereas the formoterol in the long-acting version of the long-acting formoterol, that is going to keep the airways open for up to 12 hours. So you have this steroid reducing inflammation, reducing swelling, preventing an attack from coming on, while we also have the formoterol that is actually opening up the airways, causing that bronchodilation to take place. So the Symbicort is a wonderful combination. It's a combination of steroid and long-acting beta-2 agonists to help really give that patient, open up the airways to help the patient breathe better. Again, you all would have done this in the group project. There were at least one or two groups that got this whole section wrong. The name of the device is Symbicort Turbo Healer. The Turbo Healer is a specific device. Symbicort is the name of the drug or the brand name for it. So there are different dosage forms that the Symbicort comes in, and persons didn't pay attention to that in the group project. So some persons just saw Symbicort and they started copy and pasting, and it was the wrong thing they were copy and pasting. So if you were one of those persons who copy and paste the wrong thing for the Symbicort, there is a link in the e-class. Go back and look at Symbicort Turbo Healer. You have to know how to use these things correctly. Because if you don't administer the drug correctly, your patient is not going to get better. Everybody okay so far?
Yeah.
Right. So pharmacy has Symbicort 84.5. Could we use this device to give the patient, the doctor wants Symbicort 164.5. Could we use this last device down here to administer that dose?
No.
No? Everyone agree with her? No? So she's correct for saying no. This one is 84.5. This one is 164.5. If I tell the patient take 2 puffs of this one, it then goes to 169, which is different from 164.5. The 80 and the 4.5 is the 2 different components. 80 milligrams is the budenoside and the 4.5 is the formoterol. Here the 160 is the budenoside, the 4.5 is the formoterol. Everybody understand that, right?
Yes, sir.
Theophylline. Keep in mind, wherever you see theophylline here, is the same information that you have in your group project for aminophylline, right? So we're saying here that the theophylline is indicated for the treatment of symptoms and reversible airway obstruction due to chronic asthma or other chronic lung disease, right? Generally speaking, theophylline is used when we tried all of the other treatment options and still didn't get the therapeutic response that we're looking for, right? Then is when we normally add this on. Just 1 minute. Right? The mechanism of action for theophylline, we're not going to get into. It's not a commonly used drug. Part of the reason it's not a commonly used drug is because it have like real crazy side effects. Tachycardia, heart flutter, hyperactivity in children. Then it does mess with your blood glucose. It does mess with your uric acid. It does mess with your cholesterol. It's just a messy drug. So we only use it in emergency type situations where we're trying everything else and nothing else seems to be working. We just give you this in the short term just to sort you out. And that will put into context why it's on the emergency trolley. It's for emergency purposes. The other group that we have here is the leukotriene antagonists. Montelukast is the drug name, singular is the brand name. It's generally used for prophylaxis and chronic treatment of asthma and prevention of exercise-induced bronchoconstriction. This drug, when it came to market, although it's indicated for asthma treatment, it didn't perform as well as the drug companies expected. Some of the therapeutic benefits they saw in the clinical trials didn't fully materialize when it came to market. The drug is not routinely used in asthma management anymore. Where you're going to see the drug being used is more along the lines in the ENT clinic, ears, nose, and throat, for persons who have allergy type reactions or where the allergies tend to play a part in terms of, stuffiness, that constant cold. They are the ones that tend to prescribe it more as opposed to the asthma patients, the asthma doctors. We'll skip the mechanism of action. When you look at the side effect profile, headache, dizziness, fatigue, not too bad. Little elevation in your liver enzymes, that has happened for all drugs that being metabolized by the liver. But then we get to the abnormal dreams and the aggressive behavior. And when we dispense this drug, and this drug is used in children as young as 4 and 5, we oftentimes quietly say to the parents or the caregivers, when you start using this drug, if you recognize the child is having or coming to you and saying that they are having these abnormal dreams, or you recognize that the child behavior has changed, it may be linked to the drug. And if you do see this happening, bring the child back to the physician and have a conversation. Because the longer the child is on medication, the worse these side effects become. So once we recognize that this is what's happening with the child, we try to get them off of the drug as quickly as possible. So the drug comes as a 10 milligram, a 5 milligram, and a 4 milligram. And the 4 milligram is a chewable form. So child don't even need to swallow it. They could just chew it up and they'll be good. Right? That's the end for today.
So it kind of end on a scary note, though. I felt like I was watching a Netflix show on pharmaceuticals gone wrong.
So the thing about it is, I have actually seen that happen to children, and not many pharmacists are aware of that particular side effect. They will give you the drug, especially in the private setting. They will sell you that drug, and when you ask them what to look out for, they will never tell you that, because half of them don't know, especially in the private setting. In the government setting, because we tend to have a little bit more clinical side to what we do, we tend to get into that a little bit more. And I have actually seen it happening in children, where the child will say to the parent, look, when I get up next morning, they had weird dreams. And weird dreams, for some children, it may be playful weird, where they will tell you the dreamer there was a 8-legged rabbit riding a pink bicycle. But then for some children, that could now turn into a 8-legged werewolf chasing them down on a motorcycle. So it really varies. For some children, it also presents at, and I'll use the term loosely, where as evening sets in, they tend to become withdrawn and almost depressed. Once daylight comes back, they're back to their normal selves. So it's not just aggressive behavior, it's that whole general change in the child. And for me, that is one drug I don't generally recommend to parents that they use if the physician believes that the child will benefit from it. Usually, we try to tell them, look, try to explore all the other options before adding that drug. That drug should be a last option. And as I said, in the management of asthma, really and truly, they don't use it in asthma management. Is if we have tried everything on you and it have nothing else for us to try, we'll just get that to see if we're going to help you a little bit. If we see a little thing happening, we'll continue. If not, we just call it quits and take you off. And that is why this class is important, for you all to understand the effects of drugs, and not all of them are good. Right. Any questions before we go?
No, sir.
Right. So I just have one comment, right? So last week when we were here, right, Oliver chain up and tell me, yeah, we're going and do your class evaluation, sir. One person.
Hey, I do your class
No,
evaluation,
you did it before. You did it before. But
I did it after the book Anissa gave me. I did it.
Right. So you might have been the one person, because it was one person. I was like, wait, these people are real chain up.
I'm not doing that.
I did it today.
So I'm gonna do it after.
If I do the class evaluation, I know
I will do it because you deserve it. Honestly, you really deserve it.
I would do the class evaluation, but I know that it have some people that it have a way to see through what it is you write and things on it.
Right. So I can tell you for sure on my end, I don't see who write. Let me just show you what my
evaluation long time, real long.
Right. So that's what I said. So I'm going to show you what my screen looking like. Hold on. And I'm showing you what I am allowed to see. I can't speak for any of your other lecturers. I could just tell you about me. 1 minute.
Wait, lecturers, let's see our remarks.
Yes, it is seeing the
So,
light
no, I'm going to share with you what I see, right? So it has two screens that I see, and I'm showing you. I'm going to show you what I see.
So, if you give us some exam tips, additional exam tips, I will make sure my friends in this
Right.
class.
So you see, you want me lost my little money I collected at the end of the month,
No,
right?
no.
I shared a story with you all as to why I don't generally talk about. My job is not just to help you pass the exam, it's to help you learn as well. Once you learn your work, you're good. Right. So this is the screen that I have right now. So before class started, well, this is our class right now, 256. This figure was on 5. So I checked it before class. I was like, but wait, whole week gone, one person do the thing. So I said, all right, I said, I'll raise it. During class, 2 other people do it. Thank you. But my total is 24. So you see what this does here, right? Is only 29% of the students took time to evaluate me. So it does look bad when I get a low response rate. So that is why they ask us to encourage students to give the feedback. Good, bad, indifferent, give the feedback. So
I,
this is
but I'm not one of them who didn't give the lecturers bad remarks. I didn't give them good remarks, and somehow I didn't end up paying for it.
right. So I telling you about me, I can't tell you about your other lecturers. And keep in mind,
I
after
didn't
all you finish my course here this semester, all you do see me again for the rest of all your whole course. So even if you give
So,
me a
you
bad
know,
comment, you know how to deal with me again.
no, sir. I didn't give everybody good comments, and I don't know what's actually going on with
Right.
everything else.
So
But
so
I
this
will
is
give you a good, I will give you a good comment and everything.
I want an honest comment. I want an honest comment. Whatever worked well, you say that. What didn't work well, say that. Because it allows me to find out what didn't work well so I can try to fix it for the next class. Meaning the next group of students. So this is me. So this is the screen that I have access to while the quiz is open. So I'm going to stop sharing and then show you one that from last semester when the quiz closed, what it looks like for me. As again, I can't tell you for your other lecturers. I could only tell you for me, right? Just give me 1 minute. Let me just find it here because there's be different links I just have to go to. Hold on. See reports.
So you deserve that because you're a very good lecturer. So you deserve
I
all
agree.
deserve a good comments.
And I will take the good comments, and if it had any 1 or 2 bad ones in between there, I've taken
I
that.
comment for you. I comment for you. So I being honest, right? Long
Mhm.
time I used to take the time and make sure I do the evaluations and stuff, right? But
Mhm.
sometimes I just find like it's just this long. I prefer do schoolwork instead, whatever. But I
And
would make sure I was
I can
passing.
give way to that. No,
I
I can
was
give way to that. But for me, we finished class early today, right? So all you have
yeah.
a 10 minutes extra,
No,
you
no
could take the
excuse
time.
today. I would make sure I do if nobody else lecturer, I will do yours because sir, I've been honest with you, is a real excellent teacher. This is me on my way to work and other nurses listening to your teaching and everybody enjoying your session. I sit down with my diabetic mother-in-law and she's like, "Oh Lord, I like this man, how he teaching." So I telling you from facts from my husband listening, he is an excellent teacher. My only regret was not having these sessions kind
Just
of
recorded.
recorded because
Yes.
like last week I couldn't be in class. I couldn't
Mhm.
and but I my whole week, so it really that the only one drawdown
Yes.
for me. For
And
sometimes, like I say, in the car, in the shuttle going to work, and I'm trying to listen to car write notes. That was the only one drawdown for me. But
right.
other than that,
And you
understand.
put that, if that is the case, you put that because it's something I'm trying to get Costa to resolve. Is not on my end, is on their end. Up to 3 weeks ago, I saw the IT guys in South Campus again. I was like, hey, what going on? He said, yeah, yeah, give me your number again. I'll go and try to sort it out. And he still a call me back. But it's
Send me
something
his
that they
number.
have to address.
Okay.
Sorry?
Send me his number, sir. I will sort him out for you.
Right. So what I have up on my screen is what, based on your responses, the report I get when the quiz close. So this was from semester 2 in 2003. So based on the different questions, remember they just have different categories, right? Faculty, different things. So then they would have given me an average based on each student response. This is standard deviation. This is the divisional average, and this is the school average. So they compare me to the department I am in, and they also compare me to the rest of the school in terms of all the lecturers that students would have done grading for. So that is this first section. And then for each category under here, they break it up into, well, 16 students responded. And then they give me, you know, it is be strongly agree, strongly just put it into the different percentages and just tell me this going along. And that does go through for each question. That's not. It does go through for each question, I think. This one doesn't have the graph in it, does it? And when you type the comments, this is how I see the comments. I don't see your name, I just see the comments that you left and under which heading. So this is,
I want to find out something. If I put no comment underneath the comment section, that will not be
it will come up as no comment.
all right.
It will come up as that. So this is the report that the system generates for me when the quiz closed. As I said, I could only talk about my experience and what I get. Can't talk for your other lecturers. I don't see your name, and you see I show you an actual report. I ain't getting no makeup thing. I got an actual report there, right? So if you have the time, if you can tonight, if not at some other point in time, if you could make a 5 minutes
Good,
and
good.
talk.
As the class finish, I will do the evaluation. I'll promise to put up a comment for you.
Okay, thank you.
Well,
All right.
sir, the 100 out of 10, just know it's from me.
Thank you very much. So if no
I don't
further,
really give lecturers. I don't really give lecturers thing. The only other lecturer I give a very good remark thing for was Mr. LaRose, but he was a wonderful dosage lecturer. He was a wonderful person.
right. I think I just know the name. I don't know him per se. I've heard the name around. All right. So by weekend, I will send the breakdown for the exam. And if persons have any questions as we go in, as you're revising and stuff, you're free to email me and I'll try to sort you out as quickly as possible.
Okay, bye, sir. Bye, everyone. Good luck in the exams next week.
Yeah,
Bye, everyone. Thanks again, sir.